Well, first of all, I'll say I love the whole hip pain thing. That's a lot of what I'll deal with is back stuff. But today, we're going to talk about the non-op hip management. So this is not an all-inclusive list, okay? We've already gone through what are the etiologies, the causes of hip pain, and Dr. Fowler just did this in some detail. But this is predominantly what we'll see in the clinical setting. Now, when we talk about non-op treatment options for the hip, we predominantly start off with these 5 categories, and we'll go through these in a little more detail. Most notably is when we look at the clinical evidence, probably the strongest thing that has the most clinical evidence is weight loss. And I can't tell you, I mean, if you've been here throughout the day, just about every one of us has touched upon that, and it is a real issue. It absolutely has the best clinical evidence for helping people with hip pain and for many of the joint issues that we deal with. But as is alluded to down here in this quote, it's the hardest thing that we deal with because it actually deals with trying to change people's behavior. That does not mean we shouldn't pay attention to it or counsel patients. It needs to be talked about in almost all of our clinical visits, but it is probably the hardest thing for patients to adhere to. When we get into medications, Tylenol is great. I would say anecdotally 50% of patients will tell me they don't think it really helps. 50% think it really does. I speculate that the 50% that say it doesn't may not be taking it appropriately or have just taken like 1 or 2 pills and then said, didn't work for me. The amazing thing about Tylenol, as Dr. Politi alluded to, we don't know how really the mechanism works. We just know it does. Anti-inflammatories definitely have a role in the non-op management of hip. I've taken to utilizing meloxicam. I think Dr. Politi alluded to that as well. There's many reasons for that. One, it's kind of a hybrid COX-1 and COX-2 inhibitor. So inherently it is more protective of the GI tract than say a Aleve or naproxen is. 2, it's available generic. That's great. 3, it's a once a day. It lasts 24 hours. And if, for patient compliance, anything that is once a day, they'll likely do twice a day, maybe 3 times or more, it's not going to happen. Pain medication, when we talk about opioids, probably doesn't have much of a role in this scenario because, we have such great surgical options for these patients. Now, there are always those people that maybe aren't surgical candidates or have contraindications to steroid injections or anti-inflammatories, and you really don't have much to offer. Okay, potentially that may have a role there, but I don't see a lot of people on chronic opioid medications for their hip condition like that, or that we're talking about. The other thing that I ran across as I was going through and doing a bunch of literature research on this is colchicine. Now, this is very prevalent in the rheumatologic data or literature. So it's interesting in that they're using this a lot of times in patients that maybe aren't responding to anti-inflammatories, are contraindicated to have steroid injections in the hip. The thought is that many of these patients may have some subclinical calcium-related or crystal-related disease, and that the colchicine, even used in addition to an anti-inflammatory in some of the studies, showed some benefit, real benefit compared to people just on an anti-inflammatory. So the dosing of that's 0.6 twice a day. Trial it for 3 months, assess the patient back, see how they're doing. Not an unreasonable thing to consider, although I will say in our scenario, typically the patients we're seeing are moving on, and we do have some surgical solutions for the issues they're having. But for someone that things are contraindicated medication-wise, this might be a good option. Physical therapy, quality of life. I mean, that's probably the main thing we're talking about throughout today. Everything we're talking about is about quality of life and function for our patients. And the strength is how I will talk to patients about this, because many times you say physical therapy or weight loss or things of that nature, they start turning you off. They're not listening to you. But when you start talking strength, patients hear that, and you say, strength is important. Strength will stabilize this joint. Whether you're going to have surgery or not, it's really vital that we go into surgery stronger, because your outcome's going to be better. Say you're not going to have surgery, it still is going to help you. Like I said, stabilize your joint. So that's one of the ways I'll sell it. Now, assistive devices. So something I think that's not really talked about a lot, and certainly even in clinics, we breeze right past it, is the use of a cane. Okay? Certainly in our era, I think in our society, a lot of times people will view that as a failure. You know, I don't want to have a cane. I mean, to have that discussion with the patient in the room, oh gosh, not the cane talk, you know, they're not real excited about it. But it helps. It helps tremendously. And it's maybe becoming a little more chic. We're seeing it on the red carpet more and more. But what it does is it is able to displace the forces across our hip and across the pelvis. So when we're in unsupported single stance phase, okay, it's about 4 times the body weight is placed compressive force on that hip joint. That's a lot. And I can't tell you how many people, if they do use a cane, come in using it wrong. I mean, it's a huge pet peeve, and I know the physical therapists in the room know what I'm talking about. But you know, they come in, it's the right hip's bothering, and they're just mashing everything into the right. So you want it in the contralateral hand, and as the bad leg goes out, the hip goes, or the cane goes out. And what this does is it will transmit the forces across the pelvis here, okay, when we're using the cane, and it tremendously offloads this. This can be the difference, and say someone that's going to have surgery or is going through some procedures, this could be the difference of them being able to go to their grandkids' ball game, get out of the car, make it to the field, get in and out of the store. I mean, this is quality of life. This is function. I mean, so we may look at it and say, well, you can only go 100 yards. That's nothing. But for them, maybe they were only going 10, you know, and so 100 is like, I can hit Kroger on the way home. You know, it's a big deal. And it's simple, you know. The other thing that to talk about with this is the sizing of this. This is probably a little short, all right? So probably a little bit more for style than actual function. So the correct size, you want a nice little bend here. I think, you know, roughly 20 to 30 degrees in the elbow. There are different ways to size this. The physical therapists I know are very good at this, but just suffice it to say, if it's not the correct size, they won't like it, and it causes all other kinds of problems. So they need to be in someone's hands that knows what they're doing with the cane height. Don't just send them to CVS. They'll come home with a quad cane and all kinds of weird stuff, you know. It's crazy. Okay, so now we'll talk about some of the injections that we can utilize to this and area. And we all know about the trochanteric bursa here. So we can, in the office, you know, place a little needle there, help them out, get some swelling out. There's also the iliopsoas bursa, and this isn't done quite as often, but it certainly it can be a cause for anterior hip pain. We'll usually utilize fluoroscopic guidance, and now when I start getting these up, I start feeling at home, because this is what I look at most of my week. But we'll come in from a little bit of an oblique angle here and place a little bit of now this is outlining pretty much the iliopsoas, but the bursa is right on the front top outside of the joint capsule there, and place a little bit of a medication in an effort to decrease any inflammation or help them with pain relief. Here's just another version of that, same kind of procedure off from the oblique angle there, maybe even a little more lateral on that one. I don't know if this is projecting to us, pretty dark, but this is an intra-articular injection. It's a little bit different than the bursa injection. With this, we're coming down and tapping underneath the joint capsule, and you get, I don't know if you can really see this, but there's a ring-like effect that travels around that, and that's when you know you've hit the home run. Here's another view of that. Again, the ring-like flow of our dye pattern. So it's important with this that you use enough volume so that you can make sure that even though you're just under the joint capsule here, you're going to get a nice spread up through the joint. I'll tell you, a lot of people I think that, and I've seen some X-ray images of people that are trying to get the needle actually into the femoral acetabular joint, and that's a real problem, because you can cause a lot of cartilage damage, do some more harm than good with that. But I have seen it. But really, I like coming in right about here. It's nice, and a lot of times if you're not getting good access, and this is typical of what I'll do. You just ask the patient as you're doing the procedure, hey, make sure you loosen up your hip there. It's unreal. They go, oh, you're right, I was tightening up. They loosen it, and suddenly the flow's great, and we all pat each other on the back, and it's a good day. So how often to inject? Okay, this gets brought up all the time. And I know Dr. Westerheide alluded to it, like in the rotator cuff. If you put a bunch of steroid in there repetitively, that can erode some of the tissue. In an arthritic joint, it's a little bit different. You're able to do it a little more often, but I will tell you, in looking at the data, it's highly variable, what's quoted. There are some reports of just 4 times per joint per lifetime. There's others that say, hey, once a month is fine. More of the once a month was in the rheumatologic, like RA, people that have true inflammatory disease, so you're really impacting the inflammation. There are studies that have been showing low progression rates of disease with steroid injections. There are some primate studies showing accelerated. There's a horse study, that shows increased surfactant production. So maybe potentially giving some type of protection to the chondrocytes. So you gotta utilize this information and be judicious and reasonable. We don't want to just be putting this in every month. It seems extreme. So we need to utilize our guidance here with the underlying disease process, their history, how have they responded to previous injections. We would not want to keep doing these in someone that says, God, they just don't really help me. They're helping me like a week. I mean, that's not long enough. I think in general, the accepted is about once every 3 months in a joint. It is generally accepted if it's arthritic, okay? Now, there's other conditions. And most of these people, though, progress to some other option. We may have them feeling good for a year, and then suddenly they come in and I'm talking to them, they say, I just am tired of this, I need to get this thing fixed. And we say, that's fine. They've mentally kind of arrived at the conclusion of surgically, I want to have something done. But we've been able to handle them and help them during that 1 year, keep them functional, employed, all that kind of stuff. Potentially even get them into therapy, they're stronger as they move into the surgical realm. The max that I think anyone would do is, or that we would recommend, is every 4 to 6 weeks. That's probably in extreme cases, again, like someone that has true inflammatory disease, someone that's going to end up having a joint replacement, but for whatever reason it's put off for several months and they're just really struggling. And the limitations of this are really on the systemic effects of the glucocorticoids. It can, if we keep pulse dosing, you can have adrenal effects, bone effects, skin effects. I mean, it happens. It happens in people. So you have to be very mindful of that. And there you go, close to 10. All right.